limited because we want to limit radiation to the child, isn't it? So basically, you need to rely more on your clinical findings, your clinical examination, as well as other biochemical studies and all that. Basically, that will give you more answers to in the child. Basically, what investigation that we do? So the different investigations, rather limited as I mentioned before. AXR stands for Jessica, right? Ibu tak tengok muka I tak handsome kan? So AXR basically stands for abdominal X-rays. US for ultrasound, contrasted studies, which is is a limited contrast study because we want to, as I mentioned before, we want to limit radiation to the child because the cells are growing, so they are more prone to cancers. So we do balance studies, MCU. Apa tu MCU? Anyone knows? It's a maturity during program. Basically, you tengok budak tu kencing lah, alright? And of course the CT scan. Alright. So when do you do abdominal X-ray? Okay. For children, usually the indication will be for acute or emergency setting. So what you want to find out from the abdominal X-rays? You want to find out if there's any abdominal distension. Biasalah, whether it's because of obstruction or any operation, things like that. And the other thing is for bilious vomiting in a neonate. Alright. Basically, usually for the upper GI studies lah, basically. So indication for the ultrasound, when you are suspecting if there's any mass, no use of doing X-rays because you can't see much from the X-ray. You want to see if there's any suspected hypertrophic bowel stenosis or interception. These two basically will is a second line. We will do these two will present as obstruction first. So basically, this is second line from the abdominal X-ray. And the indication for the contrast studies, well, basically from the abdominal X-ray, if there's any double bubble sign, multiple loops of dilated bowels, adenopathy, so you will proceed to these three investigations, right? So basically, barium meal is through the upper part, barium enema is from the lower part, okay, from the rectal. Depends on whether it's upper GI studies or lower GI studies. Also depends on what your clinical suspicions are. Alright? And the one and only indication for the CTs will be if there's a mass. So if you're suspecting a solid mass, then you need to do your first investigation. First line will be on ultrasound studies. And then if there is a mass, then you need to follow up with the CT scan because you need to know the definite diagnosis for the child. And we go to the interpretation of the abdominal X-rays. Easy. Basically, what you can see on X-ray is just gas, right? Whether gas or you can see probably some opacity, you want to see probably some vein mass, things like that. So basically the two things that you need to look for will be the abnormal gas collection or if there's any calcifications. Alright? In terms of gas collection, three areas. Whether it's intraluminal, abnormal gas collection within the bowel itself, outside the bowel, or in between the bowel wall. Alright, so that's what they call abnormal intramural gas collection. Alright, so all these three stands for different causes. if you have abnormal gas within the bowel, logically there is some obstruction. Yeah? Isn't it? If there is gas extraluminal, so you're suspecting of any compression, and it's called pneumoperitoneum, okay? Or retropneumoperitoneum. Or if there's any air within the bowel wall, then you're thinking of bowel ischemia, so probably some necrosis has set in. Alright, that's more towards the infection. So bowel obstruction. Proximal bowel obstruction, as I mentioned before, or distal bowel obstruction. For the proximal bowel obstruction, you need to search hard for if it's a single bubble or double bubble sign. Alright? And then the next stage will be, this will be abdominal X-ray. This is finding of the abdominal X-ray. So your next step, if you see a single bubble, you proceed with the ultrasound. Double bubble sign, you proceed with the barium meal. And for the distal bowel obstruction, obviously you are looking for a multiple bowel distension. So obviously it will be the lower part obstruction. So you need to do a barium, either barium minima or ultrasound. Okay. For example, what do you see here? Tapi tak ada nama kat yang sama. Probably they have some guy at the back, spectacles, the one with your hand on your mouth. Okay. How do you present an X-ray? In the water, in the I show you. Tapi boleh nampak kan? Okay, how do you present this X-ray?
This is the abdominal X-ray of somebody.
Somebody tu you need to kalau you tahu it's a male or female, itulah penting. But the main thing you need to say whether it's an adult or teen. Okay, that one kena mention. Kalau even though you're looking at the normal X-ray, chest X-ray, this is an adult chest X-ray, this is a pediatric chest X-ray. Now, you want to know whether it's split or not, obviously you look for the grown-up structures, right? So this is a X-ray of a pediatric patient. Okay. Then, what do you want to comment on?
Presence of resolution. Conditions.
Sorry? Obviously it's bowels, right? So bowel, three areas that can, first of all you look at the air. Macam I mentioned earlier, basically two things that you need to mention. Kalau you don't know what to say, right? Just fall back on the points that I mentioned earlier. So you look at the air. So comment on the air. So you think, is it within the bowel, outside the bowel, or within the wall? It's within, right? So obviously there is some bowel dilatation. Then, so mention just a generalized bowel dilatation. Anything else? Comment on the air. What else you want to comment on? Kita dah kata generalize, so if you can say location, yeah, that's good. Generalize means that all over lah. So anything else you want to, in terms of the air itself, in terms of the location? So we have comment on the presence of air. You also need to comment on the absence of air. Right? Absence of air tu quite important juga di sini kan. Depends on the finding kan. Kalau dia dekat area of the liver, obviously there is no air there. So, but over here there is possibility of air of the distal of the lower abdomen. Mana tak ada air di sini. So means that you can give an impression possibly there is a obstruction. Alright. So we done with the bowels. What else you want to comment on? So for kids, apart from bowels, you need to look at the liver. Is the liver, if you think there is some hepatomegaly, things like that, enlargement of the liver, that one you need to comment on. Especially in pigs, it's really important. Okay, so for the solid organ pun not much you can see. Liver, probably can see some spleen, maybe some splenomegaly, it's a bit. And then what else? And the bones. Sama tak, you need to have a checklist on that. And they may say what you want to say. Kalau tidak, kadang you dekat exam macam tu doesn't give you the good impression to the examiner, right? So have a checklist. So comment on the air, comment on the solid organs, comment on the bones, and know what to say, what to find, what to mention lah, alright? Sama juga dengan chest X-ray, the same thing. You need to the other checklist include lung field, intestinal, diaphragm, things like that. Okay? So kalau kena ada checklist, you need to do the checklist. Otherwise, you need to practice now for your viva. So obviously there's some instruction there. Okay. Next one. Nampak tak lama lah. Tak nampak juga. Ini dah tak nampak kan. Norazia Nazwa. Masih baik. Alright, okay. Present the essay.
This is an essay of physics equipment.
This is your cantik. What do you think there is? Okay, you mentioned an abnormal bowel extension, right? Or the location. And then you can mention the location. More central, peripheral, things like that. And then sign apa ni? Finger bubble sign, kan? And then there is lack of possibility of air within of the other regions of the other bowels, right? So maknanya there is some obstruction, some somewhere distal to this lah. And this usually kalau besar macam ni apa? In the stomach, right? And then what's this? If you rasa benda susah apa nak disuruh separate kan, you tak ada benda nak cakap, mula start lah dengan any foreign body dalam tu. You can say there is a NGT there, tick dekat mana, and then submission lah what signs you are looking for, yang you nampak lah. So what does single bubble sign stands for? It means that there is a gastric outlet obstruction, and the one and only cause will be hypertrophic pyloric stenosis. Okay, so basically A is what? Antrum of the stomach. Okay, D is duodenum. What connects between the two? The pylorus. So basically, there is thickening of the pylorus. So the lumen, the inner lumen will be narrowed. So that's causing the obstruction. Okay. So how do you proceed with this? Proceed with the ultrasound. Okay. So basically, usually with the ultrasound, there will be markers. So look for the markers. Ni macam abdomen markers, kan? And then look at where the ultrasound probe is. So they start at the middle. Alright. So in at the middle. So it means that what structure you are looking for? Looking at the liver. This will be the liver. Looking at the liver. So what is actually liver? This is the stomach with the content inside it. Okay. And then this is the thickening. This is on the cross section. Kalau on sagittal view, you can see, nampak? There's the thickening. Right. So that will be the diagnosis for the hypertrophic pyloric stenosis. Jadi, double sign, which stands for problem of the duodenum. So, usually the because will be midgut malrotation or volvulus. Sama ke malrotation or volvulus? the duodenum itself, there is some stenosis, another narrowing of the lumen of the duodenum, or its absence altogether. So we call it duodenal anesthesia, and there is no connection still to it. So, okay, so what study is this? Barrel meal. Barrel swallow is for the esophagus and above. So the swallow atas, kalau into the stomach already, it's a barrel meal, right? So basically you just inject some contrast and then you just do an exhalation. So what you are looking for, stomach, this will be the C loop of the duodenum, right? So you want to see this C loop. And then from the duodenum to the jejunum, there is a ligament of trace. You tak nampak lah on X-ray. But this DJ junction should be always on the left side. It shouldn't be past the midline of the spine or towards the right. Okay? So that's how we diagnose if there's any malrotation. For example here, this is a sequence of the X-ray done as the patient, as the contrast are given, right? So you can see the stomach is filled with the contrast. It goes into the duodenum, first part and the second part, and into the third part. And then you can see the DJ junction, it doesn't cross the spinous process. So that's, and then in the lateral film, you can see macam corkscrew appearance. So this is the diagnosis for the duodenum. Right? So what happened? Alright, so basically at the fourth up to 6 weeks of gestation, your abdomen is in a single file. It's a straight tube. Alright? So basically, after 8 weeks, it begins to rotate around the mesentery attachment. So that's why it became, at birth, it became like what we have now. Alright? So basically what happened in the malrotation is the large bowel doesn't move naturally, so it became in an abnormal position. Alright? So basically instead of the large bowel is there, it goes to flip to the other side. So basically valvulus is a complete malrotation. But for malrotation, any abnormal position of the bowel is called a malrotation. Right? So same thing, it can go either vertical or it can go horizontal. If horizontal, it can become and strangulate the blood vessel. Alright? So it may look like this now. So kalau what we are afraid of, if this thing happen, it can cause ischemia, bowel ischemia or necrosis because we are restricting the blood vessel itself. So the presentation will be probably at birth or probably within a month in the unit period lah. Okay. Alright. So we have seen sign of single bubble, double bubble. What happens if there is a multiple loops of dilated bowel? So it means that the obstruction will be more distal, right? So the causes will be more distal. So it will involve the ileum or the large bowel itself. So you can have either atresia, Hirschsprung disease, or interception. These three are the common causes of units or child obstruction. Alright. So what study is this? So it's enema. It's a baric enema. So we give a contrast to the rectum. It goes into the sigmoid colon and then into the semicolon. Alright. What is abnormal here? Kalau as you can see, the large bowel, the distal portion is more dilated. It's more larger in caliber compared to the proximal part, isn't it? So this is typical of Hirschsprung disease. Nodular, there is no sympathetic response to constrict the bowel. That's why it causes it became obstructed. Alright. So if you see the calibers, abrupt change of caliber like this, so it's a Hirschsprung disease. And this one. What generalized thing. So this is what you will see on the plane in the X-ray. Just a loop of dilated bowels. Okay, on the side view. Okay, you can see the changes of the caliber. So the transition between the normal and the normal part. Yeah. So basically the next topic will be on intersection. So basically what happened is part of the bowel telescope side the other lumen. Okay. So bila dah masuk itu, you can see the lumen, the part of the lumen will be narrow lah. So that's why you can cause obstruction. What you will see on the ultrasound. So basically what you'll see is exactly like this. Exactly like this. You can see on some, you can see part of the telescopic part of the bowel. So what do we do in case of intersection? So patient, kalau intersection, apa dia punya implementation? Tapi the more common, apa yang parents akan complain of? Depends on the part, boleh juga. Ini stool kan, apa yang karakteristik stool kan? So itu yang the main thing. Patient will, parents akan complain lah. So what do we do? So to treat this, it can be done in the radiology department. No need to go for touching under surgery, right? So what we do is, when the tube is still up, we put the tube inside, and then from there you just flush saline. So basically by flushing the saline, you will push the telescopic part of the bowel to out. Outside lah. Right? So this is what you see. Yeah. So basically dia basically just showing that ini yang telescopic part ni. This is telescopic part. So basically saline tu masuk and pushes the what do you call it? Pushes the bowel outside. Okay. I think you just Google or tengok those communication. Alright. So the next one will be on apa yang differential. You can see the stomach, right? There's the stomach, there's the part of the bowel, but you see the distribution of air. It macam lining the bowel wall, right? So that is the sign of intramural air. Okay, so this is the memang characteristic that you need to know this, right? Because it's what you call this render emergency cause. So what you see is, like I mentioned earlier, it's a linear cyst along the bowel wall, and when you see in cross section, memang look basically like this. Alright. Kalau if it's in cross section, dia nampak macam doktor lain. Dia tak follow the bowel itself, nampak macam tapi you'll see lah. I think you can just in the textbook what the character usually this is a bit difficult. Probably it won't come out in the result, but usually the most common one will be the one that I showed you earlier lah. You can nampak very obvious signs of it. Yes, this is supposed to show on the cross section. On the cross section, so you'll see macam doktor exclusive cyst. But the exam will be more like this. Kalau misalnya macam ni, you should suspect for another important case will be operator. As usual, the radiologists will like to do imaging stuff, so we create signs like overall sign. You have a loss of liver obesity, development sign, also known as liver signs. Or pulsing, you can see the pulsing movement. Alright. Ini obvious lah kan? can see both. You can see both sides of the bowel wall, inside and outside. Kalau dia overlapping with the bowel, it doesn't consider as regular sign. Right? You will also see dia punya liver pun tak berapa nampak sangat. It should nampak opaque, right? So over here it's more like the defined skin. And then, so this is just to show the double liver sign. So like I mentioned earlier, if it's overlapping, if it's side by side, doesn't count as a regular sign. It needs to be away from the other bowel, right? Sometimes it's overlap, so you might get confused with the overlapping of the air of the other bowels. So try to search for bowels that's away from the other bowels, and we can appreciate more of the regular signs. Alright. So this one. So kalau tak nampak, what do? You turn the patient to the left lateral ubiquitous, towards the side. Okay. So basically, this is the upper part, right? You can see the pelvis. So baringkan on the left side, you will see air. This will be the liver. Liver, you should see the diaphragm actually here, but not here. And this is the air. So in the adult patients, senanglah you can do a chest X-ray, is it? Direct chest X-ray, but on the child maybe some isolation will be. So another view is you can do a disc. Alright, then itu nak tunjuk. Alright, so we proceed with the bagian air dah settle, so this will be on the classification. Alright, cross section CT. Basically you can see this abnormal solid mass at the region adjacent to the right kidney. So CT ingat right and left mana same. Ada yang tanya you masih tak tahu right and left mana, so you need to know your indications and then try to look for the normal organs. Look for the liver, so that you know which level you are dealing with. So it's just to show the method basically. And the process of inter-examiner classification will be neuroblastoma or retroperitoneal teratoma. This is the common causes. Alright, so for neuroblastoma, it can be a fine or spectral classification. For retroperitoneal teratoma is quite major cancer, so the classification will be more close, and you can see bone formation. Sometimes macam bentuk like teeth, things like that. Okay, for example, when I say you can see opacities at the right side of the abdomen, right? So this is the classification. And on the ultrasound, hyperechoic, right, with the classification, with the shadowing. So means that there is a mass there. And of course, on the patient, you will see you'll definitely see the distinction of the patient. So that's why the importance of the clinical examination. And so basically just to show the kidneys, specified right kidney, left kidney, you can see there is a mass there. On the sound, nampak mass. Right, so basically CT is for mass. mass. Majority, most of the mass of the child will be the retroperitoneal region. If it's cystic on ultrasound and there is hydronephrosis of the kidney, you need to do NCU. Alright. If it's solid on ultrasound, then modality is more of solid treatment. Usually it will be WIMS on the child. And you need a CT for staging. Alright. And I think that's the end of the conclusion. So basically, like I mentioned earlier, you need to have a systemic analysis of the abdominal X-ray. So for the gas collection, you need to know where it is, mention if there's any abnormal gas collection, also abnormal gas absence, so you know where it is. And then mention where is the abnormal calcifications. And then with the follow-up studies, whether it's a contrasted studies like a barium, meal or edema, and ultrasound or CT. Okay? Senang kan? So, it's a problem not really sound, really also come up with this. But for X-rays, you want peritoneal, retroperitoneal, mass, and then it depends on the where it is. Fever will be up here, right? There will be the fever. Means, confirm ke budak dapat cancer, cancer. So apa yang area situ yang usually the more central. Principal he mentioned here. Linear, yes, but usually because patient should be